All right. Hi, welcome everyone. And thank you for joining us here today for our June e-learning event. So we've been running a series called Community Conversations that center community and lived experience in community-based research. And today we're really excited to have Marco Campagna, Dr. Mandana Vahabi, and Dr. Aisha Lofters with us here today to talk about the impact of COVID-19 on immigrant and refugee mental health. And as we get started here today, again, I wanted to welcome you all and respectfully acknowledge that the Community-Based Research Secretariat is located on this unceded land promised to the Six Nations. Um, Promised to the Six Nations of the Grand River in the Haldeman Treaty of 1784, and on the traditional territory of the Audouindron, or not neutral people, the Anishinaabe and Haudenosaunee peoples. It's important for us at CBR Canada to recognize this because we acknowledge that there are many different ways of knowing and different forms of knowledge, and it's important for us to consider when we're doing research as well. So, CBR Canada stands with First Nations, Métis, and Inuit communities and is committed to embracing Indigenous knowledge systems and Indigenous-led research to advance justice and reconciliation. So yeah, for anyone who is joining us here today, maybe this is your first event with CBR Canada, and if it is, welcome. But to give a brief overview of who we are, we're a membership-based organization whose mission is to facilitate connections, bridge capacities, and promote excellence in community-based research to drive positive social change. We are a national support network and nonprofit organization of 70 universities, colleges, community organizations, and over 120 individual members as well. And as part of our programs we provide to our members, we host events like today's e-learning or community conversation event, and as well as our monthly community of practices, which is happening tomorrow as well. So for anyone who is interested in exploring this further, I'll put a link in the chat that just takes you to our website where you can find out more information about our upcoming events and other opportunities to get involved with CBR Canada. And yeah, I'll now pass things over to our amazing presenters today. So we have Marco, we have Dr. Mandana Vahibi, and Dr. Aisha Lofters. So we're very excited to hear all about this project, and I'll pass things over to Marco to share his screen.
Thanks very much, Stella, and welcome everybody. Do the requisite. Hopefully you can see my screen part of the speech. So welcome. I'm going to be talking today, and Aisha and Mandana, please jump in anytime, not just at the end if there's something you want to add, about moving research to action and the idea of moving from what to now what, which is kind of a knowledge mobilization term. I have on my screen the our land acknowledgement. I'm not going to read it to you because I want to move on to sort of action oriented. So the Truth and Reconciliation Commission of Canada was created to reveal the experience and voices of the residential school system to Canadians, and to give those voices predominance. And so that was sort of the what of the commission, and the so what is the calls to action related to a number of different areas. And in this case, because we work at the intersection of immigrant settlement and health, there are two specific calls to action for newcomers and seven related to health. And so the now what of this is, what do we do with these? Most of these calls are specifically focused on government action, but all of them can be taken at the organizational level. And in many cases, they have. So if you do a search for truth and reconciliation calls to action and health, you'll see hospitals, other healthcare providers who have made specific goals or tasks or taken certain actions. And similarly, for example, while the government hasn't revised the information kit for newcomers to Canada, many settlement organizations have taken that on and have forged relationships with Indigenous communities to ensure newcomers understand the residential school history and the place of Canada's Aboriginal people. So I'm using that as kind of an introduction because that really sort of sets the stage for how I'm going to lay out the rest of this presentation. So we're going to speak specifically about the compounding COVID project. that Mandana and Aisha led. Talk about the what, so the research and the findings, and then the so what, which is what do we do with that, the community and service provider validation, the ideas from the voices of people in the community of what needs to happen, and then the now what and what we propose to do moving forward. And then, based on your Q&A, I also have a few questions we'll discuss. What does it look like to create continuity between academic or community-informed research to ongoing action within a community setting, for example? So in terms of the specifics, the I'm going to go over the research a little bit so you have a sense of where we're grounded here. So really the researchers asked what happens to people at the intersection of social and clinical disadvantage during a pandemic, specifically looking at immigrants and refugees with cancer or mental health and addiction disorders in Ontario and comparing their experience of the pandemic to other immigrants and refugees without those conditions, as well as non-immigrants with and without those conditions, and then looked at the data as well as through a social lens to see what the results were. So they looked at the data from our Ontario's databases, looking at all the way from diagnosis to mortality and what the outcomes were for different groups. And then they took that data and they ran one think tank session for each area. So one for cancer, one for mental health and disorders that was made up of members of the community, researchers, healthcare providers, as well as decision makers and policymakers to come up with some recommendations. So the so what is what they found. So what happens is that they identified a number of systemic issues from system fragmentation to social inequities to clinical inequities, all the way down to reasons why there was lower vaccination uptake, perhaps amongst newcomer groups more than others, for example. And then the think tanks came up with a number of actionable recommendations, which you'll see on the screen here, all the way from system collaboration, all the way down to a system navigation through information, increasing digital and health literacy, given the evolution of healthcare into a digital framework, as well as in ensuring that internationally educated healthcare professionals had a deeper role in the healthcare system itself. And so we worked with them to then take the findings from the data as well as from the think tank recommendations to go back into the community to newcomers as well as healthcare and immigrant settlement service providers to look at how can we take this information and ask the question about how we can have a healthcare system that supports newcomers a little bit better. And what you see is not really a mystery, right? So everything that was the recommendations that were made were validated, but they also came up with additional insights, particularly from the newcomer communities that we spoke to, because the reality is that people know what they're experiencing, they know what they want, they know what they need, and they have pretty high levels of understanding of what's possible in the different systems, even though there are some health navigation and health literacy challenges. People know that they're getting healthcare, for example, from healthcare providers, but also adjacent organizations like settlement organizations who are advocating and leading them through the system. And so when they look at the system design and the kind of reform, it's not just a healthcare design and reform, but they also talk about things like every other Ontarian talks about longer wait times. So the issues transcend boundaries, but there are also nuances to these kinds of issues. When we also talk to healthcare and settlement service providers, we talked a lot about what health equity looks like and means in practice. And the reality is that it's quite fragmented. We have lots of ideas, we have lots of research, we have lots of recommendations, but there's still a sense at the implementation level of fragmentation and inconsistency, which of course then impacts the service delivery itself. And when we looked as well at what else was happening, this is just a smattering of other research that was being done at the same time that was asking similar types of questions. This is both community research, academic research, organizational level research. And I threw in the bottom some research that we did with the City of Toronto from 2011, just to reflect on the fact that these are the answers, the questions, they've been asked for decades. So that Global City Newcomer Health in Toronto report itself was based on 20 years of evidence and research. And so we're 15 years later, we're asking similar questions and we're providing similar recommendations and similar answers to some of the challenges that we have known for a very long time. So when we look at what do we do with this information, we've started to realize that in spite of the evidence and the mountains of evidence and the knowledge mobilization around that evidence and the validation of that information, we still need to figure out ways to connect the dots for policymakers because the evidence is not moving into practice in a meaningful way in our experience. So some of the questions we need to help them answer is, what does this data explicitly say about lived experience? Where are existing policies failing the community? What specific policies, guidelines, funding guidelines, regulations control or impact the issues? What are we proposing that is concrete and measurable? And perhaps equally important, or maybe the most important, who do we target? How do we target them? And when do we target them with these concrete alternatives, with these ideas, with these changes? And when we look at connecting the dots, there are so many dots, right? This is just a snapshot of the immigration and health actors within government at the federal, provincial, and municipal levels. And there's a sense of perhaps a lack of connecting the dots even at that level within the mandates that they all have that are related to similar outcomes but are implemented in different ways. And then there are inconsistent internal dots that aren't being connected. So the Auditor General in 2023 did a number of value for care audits and looked at the fact that even within the Ministry of Health, they're not making use of the evidence that they developed themselves through Public Health Ontario. So internally, the dots aren't being connected, and we're proposing external dots to connect them to. And then things like costing. And one of the dots that we don't always do a good job at is the cost of our concrete solutions. And so we're seeing now that the Auditor General has told us in 2023 that if we can redirect people to primary care, it'll cost 3 times less than going to the emergency department. So there are real costs to service interventions that lead people to the right place. We also know, and this is from earlier this year in February, a study that talked about how amongst resettled refugees who are receiving support, whether privately sponsored or government assisted, that they're based on that healthcare navigation support that they received during their early settlement, they accessed primary care. Their children access primary care more than emergency care versus Ontarian children who access emergency care more than Ontario care. But that shifted after 2 years, after some of those supports went away, after they started to do more integration, after the financial support disappeared, and they may not have been able to access adequate financial support or employment because we know that that is a social determinant of health that impacts newcomers very deeply. They resettled refugee children also started to follow the norm, the pattern of accessing non-urgent emergency department visits rather than primary care. And so the question is, okay, we know that. So what do we do about that? We also know that the nurses unions of Canada have started to do some of the quantifying for us to talk about the ROI of investing in the healthcare system. So we know that every dollar that is spent on health generates GDP, it generates healthcare workers, it generates something in the economy. And we need to also try to figure out, we can't just make the arguments about care anymore. We have to figure out ways to quantify that. And that's something that's a little bit new and a little bit different as community-based researchers and as community organizations and even as researchers to look at the numbers in a way that we haven't before, because that's part of the argument about who we're trying to make the argument to. So when we look at the who we can impact, how and when in this project. We were doing this in the middle of last year, and Ontario's Primary Care Action Plan had just been kicked off last January, which over between now and 2029 is a $3.5 billion investment to connect every Ontarian or everyone who lives in Ontario to primary care. And we looked at that as a possible trigger point, as an opportunity point. Ontario Health in 2020 also implemented an equity, inclusion, diversity, and anti-racism framework with specific plans for the Black community, First Nations, Inuit, Métis, and urban Indigenous communities, a health equity data strategy, 2S LGBTQIA plus care, and high priority communities. So communities that are negatively typically impacted or have health deserts, for example, as well as the regulatory commitment to French language services. So we thought, is there an opportunity here to connect this mountain of evidence, the work that Mandana and Aisha have done as well, so that we can create an Ontario where the health system is built with newcomers in mind when they get here? And the building blocks are here. So this is just a snapshot of the equity, inclusion, diversity, and anti-racism framework to give you a sense of the pieces that on paper are represented adequately. So we have foundational building blocks that we can use or refer to with the evidence that we have about potentially creating something new. This framework is also built on a health equity foundation. And for me, when I look at the concepts of health equity, they're very similar to what we talk about in community-based research, right? Trust is essential. And we know from the research that's been done for this project that trust is a huge issue in one of the social and cultural inequities. We know that involving people from the beginning in service design and evaluation is essential, just like it is in community-based research. We know that building those relationships amongst organizations and across sectors is important. We know that genuine commitment to equity is essential, and that's one of the things that we found when we spoke to to healthcare and settlement service providers. Is there are a number of organizations that have health equity policies, but the commitment necessarily in terms of practice isn't always there. And the last, which leads is going to lead through to the final thread for this conversation, is that effective implementation support. So how do we address the resource limitations? How do we take knowledge and move it into actual action over a sustained period of time? So one of the things that we know from all of the evidence, all of these dots, when we start connecting them, tell us that the Ontario plan to statistically move 1.8 million Ontarians to primary care alone will not work, right? And we know that from the evidence that we have that there are other things other than trying to attach people. There's that community trust. There's nuances in digital health that we're moving towards. There's nuances in linguistic access. There's a number of different issues related to making those dots work, basically. So when we look at the newcomer in the center, and attachment is essential to making sure we have a functioning healthcare system for them, we can't do that without adequate engagement, which means going to them, not just saying, here are all of these, we funded all of these new primary care teams, now come and find your doctor. It is going to them and helping them understand that these doctors are going to manage them with equity, right? They're going to take on the nuances of a newcomer community and ensure that if it's necessary, interpretation is going to be there, that we have internationally educated health professionals who represent these communities so people can see themselves in their healthcare provider. We're going to create access in a way that is meaningful. So we don't just say you must travel for an hour, but we might have something in your community for you to access, more neighborhood community care, more community health ambassadors, more people going into the community to talk to newcomers about their health care and the importance of the primary care system in terms of helping them with their long-term health. So we don't see an ongoing challenge of what's known as the healthy immigrant effect, where healthy newcomers come and over time their health sometimes deteriorates, both because of their experience in settlement and also because of the lack of access that they traditionally have in some cases, in some communities, in some geographies, the lack of access to actual care. So attachment alone, the evidence tells us, is not going to be enough. We need these other pieces of engagement, equity, and access to make sure that going forward, newcomers actually get the care that they need. Or otherwise, we'll connect 1.8 million people, and then they will drop off from accessing that care because they're not being cared for in a way that is that works for them, that is welcoming, that is inclusive, for example. So, as part of one of the outcomes of this project, we started to think within the framework, the Ontario framework, the equity, diversity, inclusion, and anti-racism framework, what might a newcomer health plan look like that is nuanced, that is realized in practice for newcomers? And could that be important? Could that be a policy goal that we reach towards? So this is the now what coming out of the system. And so we've conceptualized some ideas, but the goal is to move forward in a co-creative way with communities, with newcomers, so that they're leading at the helm. But it's building on the evidence from this project and from every other project that has looked at these kinds of questions of newcomer access to primary care and public care and healthcare in general. So ensuring that there's collaboration, a recognition of the importance of not just health actors, but settlement and other actors in the navigation process, that that care is culturally and linguistically responsive, that we have not only mandatory health education training, but a real step towards international educated health professional integration in this province, that the social determinants of health are considered in the care model, recognizing that that is a large policy shift in some ways, where the Ministry of Health alone has to be able to can't solve this issue, has to work with every other ministry and government to ensure that they're moving towards inclusion, integration, and their own kind of newcomer plan. Robust data and research and accountability. So as you may have noticed in the framework, health data is being collected. So that's great, but what do we do with that data? We need some accountability to learn from that, some transparency and some action based on that, so that it's a living system that shifts and changes based on how newcomers are experiencing it, the feedback they're giving to that experience, and the realities and the outcomes that are happening in that in the healthcare system. And all of that requires that kind of community outreach. So not just newcomers at the helm, but constantly being involved, constantly being part of the system and leading the understanding of how the healthcare system needs to shift and change for them. So when we talk about the importance of the research, one of the things that I know in the immigrant settlement sector, as well as in the healthcare sector and the specific newcomer side of the healthcare sector, we don't lack for evidence, we don't lack for information, but we lack for continuity. We lack for long-term community involvement, and we lack for long-term collaboration in many ways. So the trick for us is to try to figure out, how do we shift from that knowledge mobilization into something that has policy implications that can actually make the kind of change. And for us as a community organization, we saw our partnership with this research project showed us that there's something more that needs to happen that is within the work that we do, in terms of we've created some of the evidence ourselves, but being part of this project to see the evidence realized for us that there's a policy implication that goes much further than the recommendations in all of these reports, and that we need to try to figure out how to move that to action. And so the trick is, how do we move from research into continuity, right? Because research projects end, researchers move on to the next project in the same way that our programs are funded and end. But the continuity at the community level is something that is really important in order to move these kinds of projects forward towards action and towards policy shifts, for example. So I have a few questions that I'd love to discuss. And just to let you know, I've put in the slides, which you will get, all of the links to everything I've sort of talked about, the resources, the research project, our knowledge mobilization efforts, the conceptualization of the newcomer health plan, for example. So some of the things I'm interested in talking about is, how can we better connect that research to community continuity? How can we be intentional about making sure that community research actually has a policy lens in it that's baked into it, or that supports the community organizations on the long-term work that they're going to be doing. And by community, I don't mean just formal community organizations like ourselves, but also informal community groups who are working on these things, who are part of some of that gray literature and community literature I mentioned earlier. They face these challenges constantly. So if we're doing research on that, on trying to address policy change, how can we explicitly build in an outcome that isn't just information sharing, but that is a policy shifting activity and outcome, so we can connect those dots for policymakers and decision makers. So that's my spiel, and I'll end it there, and we can dive into a conversation.
Wonderful. Thank you so much, Marco. That was a fantastic presentation. So now, yeah, we'll turn it over to our Q&A. So if there are any questions that anyone has, you feel free to put them in the chat or to raise your hand, and we can have you speak them out loud.
And I threw my discussion questions at the end as well into the chat.
Perfect. All right. It looks like we have a question in the chat, and then we'll turn it over to Denise. Um, Sonika says, what are your thoughts on involving nonprofit community groups within research, because they already have the trust built with the community?
Yeah, we are a nonprofit community organization, so I would say absolutely. And I would add to that, I would say not just nonprofit community groups, but informal community groups are essential to be involved in the process as well. One of the things that we're exploring as we try to move the idea forward of a newcomer health plan, and one of the experts on our collaboration is focused on co-creation. And one of her struggles has always been trying to convince both organizations as well as policymakers of the validity of community knowledge and community recommendations. And that is always a challenge. It's less so we get it as community-based researchers, right? You go to the community because they have the lived reality, and in a lot of cases, they know the solutions. And so if nonprofit community groups have the trust with the community, fantastic. But we can't assume that they do either, right? And I think we see that in some of the research. We are as well. We offer primary healthcare services as well as community services, and we reach directly into newcomer communities, and we see referrals from people who don't necessarily work with those populations well. So yes, we have built that trust. People aren't getting served in some cases. The goal is to make sure they get served wherever they are, so they don't have to come to a newcomer specific organization. So all of that is a long-winded to say that absolutely from the beginning, not only community groups, but community members themselves need to be sitting at the table in that. Let's even come up with the research questions with them. Let's come up with questions they've been asking, and try to figure out a way to help them solve those challenges in their communities. So absolutely.
Fantastic. Thank you for that question, and thank you, Marco, for such a thoughtful answer.
Yeah,
Can
and
I
please,
just
Aisha,
add?
Aisha and Mandana
Yeah,
jump in. Oh
yeah.
yeah, go on. Perfect.
So thank you, Marco. You responded quite well, but I think it goes more than that. Like, I mean, usually as researchers, we do engage quite closely and collaborate with community centers. As Marco was saying, like they are the ones who are more involved with the needs of the communities that they are serving. Having the community members, affected community members, really plays a crucial role in the research. And I sometimes really like that idea of sitting down and coming up with a research question. Unfortunately, we are sometimes limited with what the priorities of the funding agencies, the ones that have the money in order for us to do the actual research. So those funding agencies have their own priority. So that means that for us, for the community to be really engaged, we need to influence even the funding centers, agencies, the tri-councils, in terms of why it is really an important factor that the community-based research should be acknowledged. And we really need to empower community members. People come here as immigrant refugees. They come with the hope that they are going to have a better life when they come, and most of them, they are coming here with certain credentials that they feel that the Canada is interested in them. Yet they come here and none of those credentials are going to be accepted. That's why for the first 5 years they may be healthy. After that, their health deteriorates. So why that should not really happen. So the fact is that most of the immigrants, they feel really powerless, and we need to engage them, and we need to make them really realize that how important their role plays. This place that we have selected to settle down, that means that this is part of our life, and we have to make a change in it. So I think it's not like a clear answer in terms of who can be involved, and then suddenly we are going to actually reach to that miracle that we were looking for. It seems that it really requires work across different kind of sectors, and how we as immigrants, because both of us, like Aisha and myself, they have actually are immigrants coming to Canada. So that means that we really want to make sure that our voices are being heard in across the policy, services, the practice, and everything else. Aisha, do you want to add anything?
I mean, I think both you and Marcos, I think, did a really great response to that question. I would just say, I think that it is something that we take seriously as researchers, is recognizing that it does put us in a position of privilege from that perspective to be able to apply for funding opportunities, to be able to ask research questions. So we do always try to really be mindful about who do we engage with this research question, whose research question can we enable through these processes, and making sure that we're working with partners who not only have the trust, as was noted in the question, but sometimes have the expertise that we just don't have because we are, at the end of the day, part of these larger institutions.
I do just want to add one last thing as well. Mandana, when you were speaking, it reminded me, for Sonica, is one of the things that we've seen it be really important is the inclusion of peer researchers, people of the community. And I threw in response for you, Sonica, we have a toolkit called Everyone Can Do Research. Everyone can be trained on this, but there are many, many, many international immigrants and refugees with international research experience who can be brought into a research team. And what we found in some communities, in fact, that is the difference between getting information and access to those communities and not. Because the trust again is important, and as we see, if folks are following research and news, increasingly trust is a massive issue in healthcare and in community care. And so having peer researchers on your team also matters. It sends a message that they're at the table, and it also sends a message that you understand that people in the community may need to have folks from their own community to speak to and to be part of. And that has an impact in what we've seen in some of the research related to uptake as well as not as access.
Amazing. Thank you. And now we'll turn things over to Denise.
Hi, everyone. Thanks for the presentation and the answers and information provided so far. I feel unclear about. I am immunocompromised, racialized, disabled, and continue to mask as the pandemic continues, in addition to other mitigations. And in spaces, whether it's social service agencies, going to the grocery, going to my family doctor or other specialists, basically anywhere I go, there's increased risk. And I think about the role of disability and COVID being described as a mass disabling event that continues, not in the past tense, continues to provide real risk for somebody with precarious health. And I also think about the intersections of newcomers who are disproportionately at higher risk of COVID exposure because many of the jobs that they hold and or the housing that they have increases that exposure and risk. And they may be in situations where there are not protections in the workplace, like they may be discouraged or prevented from wearing a mask. Or social service agencies where no one is masking and the indoor air quality is not good. And so those things compound. So I'm trying to get a sense of where disability and the disproportionate higher risk of exposure, severe infection, and potentially disability or death intervenes with this research that's being done, because I've participated in mutual aid mask blocks where I've delivered N95 masks to some refugee health organizations in the Hamilton, Burlington area that they either don't have or like they were happy to receive. I don't know if people ever used them, but there is a lot going on where people are at risk and that's not being acknowledged. Like you go to the hospital and it's just an opportunity for risk and infection. Like as an immunocompromised person, I don't want to have to go to the hospital at all. Heaven forbid I would have to. Like, I don't know how I would manage that. Like, I am surrounded by risk in so many different places because people have moved on thinking that the pandemic has ended. The emergency did. The protections got removed, and navigating COVID as a given, as opposed to like, this is a real risk. And newcomers and racialized and Indigenous, Black and Indigenous populations continue to be at risk, but the policy doesn't reflect that. So I'm listening to this today and I'm still wondering what that looks like.
I don't have a good answer for you, to be honest, but in our attempt to create this sort of nuanced health plan, um, one of the conversations we've had is that other than folks with an Indigenous background, everyone has a newcomer past. And so if we're working on a newcomer health plan, it has to lift everyone up. And the intersectionalities that you mentioned are essential in that. So we can't have a newcomer health plan that doesn't address ability and race and gender and all of those things as well. And the idea of trying to take what we learned during the pandemic and applying it today is one of the challenges that I think we've seen fail, right? We learned a lot about those intersectionalities and about the vulnerabilities of people during the pandemic. Right, it is ongoing, of course. But specifically during when we named it, when we officially called it the pandemic, and we haven't taken all of those. And in some ways, I think because there are costs involved, there are choices that have to be made, there are policies and practical guidelines that have to be involved at the organizational level. And I think that's part of why we need these nuanced conversations in the equity, inclusion, diversity, and anti-racism framework, is to say that there are pieces that we're missing if we don't build this framework equitably. So right now, for example, the only place where newcomers are mentioned in the framework is under the Black Health Plan, where refugees are mentioned, and that is misleading and inaccurate on a multitude of different levels. And similarly, what you're describing is not addressed at all in that framework. And so that's something that, if we're moving forward with true community engagement and community-led creation of a policy advocacy plan, it has to ensure that every voice is there. And I can't guarantee that that will shift policies for everybody. But what you're bringing up is the reality that there are some voices that may have had a moment, and that moment has passed for bad reasons or for many reasons. And how do we ensure that they're included? How do we ensure that the most vulnerable, the smallest groups that are perhaps affected deeply have a voice at that table as well? And that's why a plan like this that builds on the building blocks that the province has is essential, because we can't exclude voices. We have to include, we have to open the tent. I don't know if Mandana and Aisha have anything they would want to add.
Just wanted to say to Dennis, thank you so much for your comment and inquiry. And I think this is really an important issue that I guess our research started from that perspective, because we do know that immigrants, refugees, social situation is really put them at a very disadvantage, correct? And now what Dennis you are raising is that, look, my condition, people who are not don't have limited ability, for example, they are put in a more difficult situation. So in our research, and unfortunately there is no data that specifically can help policymakers to come to this conclusion that these issues are important to consider. So more research in this area is really warranted. And what our study did, try to look at the intersectionality of not only social but also clinical disadvantages. So we looked at people living, immigrants and refugees who are living with cancer, a situation where their immune system is compromised as well during the COVID. And our data, and I have put the link to our website, you can see that there was 4 times more likely for those people to die as a result of the COVID because of this kind of situation. So these kind of analysis, because they try to actually look at the whole population majority of time, and government usually is intended to really provide policies that are targeting everyone. We want to actually, our kind of research is trying to show that there are different groups that needs more need that has to be addressed. And I think these kind of questions that you are raising and this type of research, and also the fact that our voices needs to be heard through any kind of activities, whether it's research, whether it's really a community forum where we are going to be discussing that, inviting politicians to come, particularly they're very interested during the election time to hear more and try to actually make an influence on it. So Denise, your point is well taken. we can't really, at the moment, there is no solution. And that's what we are here, just trying to actually work together, be united, and actually move to bringing that kind of change that you don't really have to be afraid of going to certain places because of the conditions that you are going to have, and no one is really paying any attention to it. So that's, and I don't know whether I'm sure I'm not answering your question, but I'm just saying thank you so much for that great comment that you have put, and just reemphasize that majority of us who are working in the area of equity, myself, Aisha, like, and Marco, like Access Alliance, like we are really interested in that kind of lens, and we are really focusing on more marginalized groups in order to make sure that their health is also is going to take into consideration. Aisha, do you have anything to add?
The only thing I would say, which really is just echoing what you both have said, and really is echoing your question, Denise, is that just as Mandana said, there's often this move by policymakers to come up with one solution, one approach, one policy. And that doesn't work anywhere, but somewhere like Ontario or Canada, where there's so much diversity, whether we're talking ethno-racial, newcomer status, socioeconomic, like there's so much diversity here that one approach just, it doesn't work for everyone. It works for some people, and I think it works for those who are systemically centered, but it doesn't work for people who are systemically pushed to the margins. And I think that is ultimately, just as Marco was saying, this has been going on for decades, and it's how to get policymakers to understand that that single approach is actively disadvantaging some people.
Thank you all so much. It was really insightful and thoughtful. And we really appreciate your question, Denise, because these are the times to have these conversations, right? This is how we push the agenda forward, and how we make change and make progress as well. So thank you. Do we have any other questions? If not, we can turn to maybe some of Marco's discussion questions as well.
Yeah, I'd love Mandana, because you brought up the shift in funding that would be required in order to do some of what we're talking about here in terms of the long term, the continuity, the policy advocacy, for example. What recommendations would you have to a funder in order to make that work?
I think just like health, when we look at like one approach doesn't really fit everyone's needs. So I believe with the funders right now, for example, most of the tri-councils funding are really targeting on certain kind of issues that is important for them, not necessary for the diverse communities that they are serving. So that's one thing that we would just say, that they really need to have a larger umbrella, that it would really provide funding opportunity for those kind of research that targets those marginalized community members that are really in need there. That's one thing that I think is really important for us to communicate with them. At the same time, right now, the emphasis and what government really wants to provide more funding is basically AI related. So, and everyone knows that digital, resources are not easily available for the marginalized group who are really taking the major toll of this burden of the disease. So again, I believe that if I was asked to give input, these are the two areas. First of all, don't forget EDI. I mean, during the COVID, that was the only time, because of the effect that it had. And you see that more, I mean, immigrants and refugees are only a quarter of the population, correct? 25%. And yet COVID-19 was almost 50% of the population was affected by it. That's really like, I mean, when we hear about it, it is shocking. So because of the impact that COVID was having, government started even becoming more inclined to EDI. And now, afterwards, as Denise rightly said, COVID is not really finished yet. We still are getting cases of COVID, but it's not as bad as during the 2019, 2020, and 2021. But it's still there. But the government is easily forgetting the EDI. It is there just, as a formality, but the commitment has been taken away. So I think three comments I would be making. Please commit to the EDI. It's really important, particularly for immigrants, uh, uh, because I feel that we as immigrants, we should also have our own voices because our health should matter there, not just particular groups that we want to put on the agenda, but also the immigrants, refugees' health, which is really important. And Canada has a large concentration of their population of that. The next thing is that try to look at the issues that are really more relevant to these communities rather than more basic research, which is important, but also it's important. Another issue is really population level kind of studies that we could actually bring those findings toward the attention of the policymaker. And the third is that please, when we talk about AI and you're trying to promote it, it's in our educational system now. Everyone, we are encouraging students even to use AI in different kind of engagement from the clinician. We are also encouraging them to use AI. So it is really important for us to pause for a moment and see if we want, there should be equitable access to these kind of things as well, and what we do. This is what I would be treated, major thing that I would say. But I'm sure Aisha may have other things that could be added. Aisha, would you like to say anything in this regard? Particularly with your experiences as reviewers for the tri-consuls and also like a chair of public health. Thank you.
Yes. So Mandana, one of the things that you said made me really reflect on oftentimes when the funding agencies, they will have a request for proposals and they will have priority areas. So areas where there's going to be like a special focus or where they're really looking for particular topic areas. Certainly AI has been one of those the last few years. There's always these priority areas, and I don't know how they are determined, but I think there's an opportunity for those to be determined by community consultation. And again, not certain communities, like not certain communities who already have their voices there, but doing community consultation to understand what matters to people who are most affected by the healthcare system and how it's structured, and having priority areas for funding really based on that. The other real challenge that I've experienced with funding is there's certain bureaucratic requirements. You have to be tied to particular types of institutions. And there are lots of, as you were saying, Marco, there are lots of people out there, peer researchers with great research ideas, and that door is locked to them essentially, unless they are able to find someone in an institution with certain qualifications. I've even had, sometimes community members have to put together a CV, and it's very discouraging if you don't have kind of these very traditional academic items to put on a CV that's then adjudicated. So I think for them to really start thinking differently about who is allowed essentially to apply for funding, ask research questions, and what what on paper do people think is required in that regard.
Thank you both. I just want to read Kate wrote, I think another key for implementation is setting aside funding to ensure that results are published or presented in layperson's terms or translated as needed for the communities that you're engaging with. People in our community orgs can take action, but sometimes your standard research papers are a barrier in themselves as well. Yeah, I completely agree. And this is where this project excelled, I would say, is that absolutely Mandana and her team published in academic journals, but they also published think tank reports that were very accessible, did webinars, published infographics, and that absolutely is essential for this type of project. And when we went into the community to do some validation, we were able to take that with us and work with interpreters during our sessions. And because we weren't ourselves having to reinterpret an academic journal and then represent it, we had the clear language, accessible information. It's incredibly important. And I absolutely agree with you when we're looking looking at, because that also matters for policymakers. Not all policymakers are academics, and so we need to, what was the line from the movie? Tell it to me like I'm a 4-year-old, right? Like we have to connect those dots for people in a way that makes sense in their context. So if we're doing that for policymakers, whether it's a policy brief or connecting it to a piece of legislation, we absolutely have to be doing that for different audiences in that process. So it's an excellent point. And Denise, you wrote, where do disability and accessibility within and among the compounding intersecting identities and social determinants of health within this research generally and specifically related to COVID and refugee and immigrant communities? So I think that's for you, Mandana. I feel like you sort of addressed that in that,
Yeah.
that in this case, it was people with cancer and people with mental health and addiction disorders.
Um, um, Thanks a lot, Dennis, for asking this question. For us, we looked at cancer and mental health and addiction. So that's the component of chronic conditions that we looked. And in terms of accessibility, we were trying to look at first of all, we wanted to make sure we have the context that where these population, because we looked at more than 11 million people, Aisha, I believe that the total number of the sample size was about more than 10 million. So because we use the databases, so we wanted to know their social conditions in terms of the neighborhood, the income, all of this. Then we looked at whether they have access to primary healthcare. And to our surprise, they didn't. So, which wasn't really, again, as Marco was mentioning in his presentation, we have a lot of data and information, and yet these information has never been mobilized in terms of impacting the policy that we are hoping could bring further the equity there. So, and because we were focusing as immigrants and refugees, and then immigrants and refugees with living with cancer, these are again the kind of information that is not available. So we realized that among the immigrants and refugees, for example, 0.9% suffer from cancer. And we looked at different kind of cancers that they were living with. And then of those who were living with cancer, 15% also were suffering from mental health and other kind of conditions as well. So the impact of cancer on their mental health was also captured there. So these are the kind of issues. And with the mental health, again, we don't really know what the proportion of immigrants and refugees with the mental health and addiction. So our study was able to actually shed light in that. So we realized that about 9% of the immigrants and refugees are living with mental health and addiction. And the major condition in this area was anxiety. And I don't think anyone will be surprised to hear about it. So the reason that we weren't able to explore other areas of accessibility, like specifically that, when you think about, is that the data that we have used is the data that is collected at the hospitals, for example, or in different kind of databases that we were actually like the census. And so these kind of databases are not, provide all the information that you need in order to conduct a comprehensive analysis of it. So we use any of the variables that could really talk about the social and economic condition of the participants, as well as their access to healthcare services. So those are the areas that we looked. Aisha, am I missing anything?
No, I don't think so. I think that was a great summary.
Wonderful. Thank you. We probably have time for one or two more questions. So if there are any, feel free to raise your hand or put them in the chat.
I'd love to ask one of the questions that I wrote to the group in case there's someone here who is working on this. So if you're working on research to address policy change, how have you constructed your project to explicitly build in those policy shifting activities and outcomes, connecting the dots for policymakers? I'm wondering if anyone here is actively working in that space. and has advice. No problem. We'll keep looking and sharing. Mandana,
And
yeah.
Marco, I think one thing that we can really use a lot is leveraging media. Because when there are issues that media becomes interested to know, then the policymakers pay more attention to it. Myself, like I have tried to actually reach out to the Minister of Health. I remember particularly with cervical cancer screening using HPV self-sampling, and no one was responding. That was really a shock to me. I contacted Ontario Health and tried to actually talk to someone trying to share the findings, and they weren't. But then I started using the media, and it created more attention there. People started, you would see that more interest is becoming toward these things. So I think we rarely use media in order to support some of our, positions that we want to actually undertake. So maybe that helps. I don't know.
That's great. I appreciate that. Kate, go ahead.
Thank you. I just wanted to add to that as well, and about your question. So I work in like the communications side of research. So obviously I'm not the one doing the research. I'm just trying to, translate it for folks. So to go with the media piece as well, one of the partnerships that we're involved with is looking into like technology that works with for dementia. And so like different tech-enabled solutions and such. And so one of the things that we've been doing is having an event, and it is a hybrid event, but we actually target specific policymakers, invite them out to come to those events, and also like through our website, and anything that we put out is really in those like, again, going back to my layperson's terms, for lack of a better word, and putting those pieces out and trying to get those messages out, and making sure policymakers are actually at those events and participating and things like that too. I know the one event we had, we knew a policymaker was going to be in the room for this, specific time period. So we actually switched up the session so that we could make sure they were actually at our event for that session. So that they heard that research. But yeah, I think one of the biggest things as well, like from the other side of it too, is trying to convey to researchers the importance of that. And I know that's something I struggle with. Like obviously you folks are all wonderful, I would say, obviously, about communicating those pieces out. But for me, one of my struggles is really getting those researchers to understand the value in making your research accessible and putting it into words that, policymakers or general everyday folks can understand and learn from, and that type of piece too. So sorry if I went on a bit of a rant there, but I think in short summary, I just like the way that we convey as well, events and marketing pieces and things like that really helps with policy change too.
Thank you. Yeah, no rant at all. That was really helpful and built really nicely on Mandana's comments. So thank you very much.
All right, we're nearing the end of our session today, and I wanted to thank you all again for the wonderful presentation, the meaningful discussion that we had, and just, yeah, being open to having this open conversation, and how we can move forward as well. Usually at this point, I'd share some of our next upcoming events, but CBR Canada is taking a pause from our programming during the summer months. So in July and August, we won't be running our e-learning events or our community of practice, and then we'll resume in September with the fall and with everyone going back to school and such. However, we do have our last community of practice event for before we go on summer pause, which will be happening tomorrow at 12 p.m. as well. So if any of you are interested in joining and having some discussions around community-based research methods training, we'd love to have you there. All right. Thank you all so much again.
Thank you very much, Stella, for having us, and thanks everyone for joining.
Thanks, everyone.
Thank you. Thank you.
Thank you. Have a great day, everyone.
Bye-bye.